Our topic today is sequential segmental approach to congenital heart disease and the nomenclature of congenital heart disease. This lecture is part of the review course of the Egyptian Society of Cardiology. So, although nomenclature of congenital heart disease is a fundamental part of the training of pediatric cardiology, it is quite a less familiar territory for adult cardiologists. But nowadays, with the majority of children with congenital heart disease surviving into adulthood, an understanding of these conditions is extremely important. So what are the learning objectives of this lecture? First, to understand the various segments of the heart through their intrinsic morphology, and then explain why do we need a segmental and systematic approach, and then learn how to use echo in the diagnosis and nomenclature of congenital heart disease through sequential segmental analysis. So sequential segmental analysis was first introduced by Anderson et al. In the early 1980s as a clear way of describing the malformed heart. So instead of using names which do not tell you as a clinician or the surgeon anything, like a Tau-Slimping anomaly or a Horn's heart, it allows anyone to read the diagnosis and immediately envision the anatomy. So why do we need a system? We need a system because there is a need for a logical approach, and it accounts for all possibilities. So we divide the heart into three segments: the atria, the ventricle, and the great arteries. And this makes understanding complex congenital heart disease much easier. So what is the approach? We analyze in three segments. There is a limited variations within each segment, which we're going to talk about later. There is a limited number of segmental connections also we're going to talk about later in the lecture. And then there is any number of associated anomalies. So think of it like a house with 3 stories where you start building the first floor, and then the second floor, and then the third floor, and then we see what we get at the end. What do you use to do that? Echocardiography. It is essential in the assessment of cardiac morphology, and it requires an approach that allows for the assessment of cardiac structure in a systematic manner without any assumptions. For example, is the right atrium on the patient's right side? Is the right atrium connected to the right ventricle? Does the right atrium connect to the right ventricle? Does the right ventricle connect to a pulmonary artery, to the aorta, or both, or neither? Is there a right ventricle in the first place? So these are the questions that you have to answer. What is the challenge in doing an echocardiography is conveying to others the acquired 2D image into a 3D model representation in your heart using the segmental approach. So you use things like morphologies, like connections, like relationships, and each of them has different separate terms. So for morphology, you use anatomical terms. For connections, you use terms like concordant, discordant, double outlet, double inlet, etc. And for relationship, you use spatial terms. So right, left, superior, inferior, these are the terms that you use. And one important tool, very important tool, is that cardiac structures are identified by their intrinsic morphology, not by position or by the echo views you're taking. So let's go through this. So the first step is to identify the atrial arrangements, which atria is to the right, which atria is to the left, whether there are 2 identical atria, right or left. And then the second step is to analyze the atrioventricular junction, and the atrioventricular junction comprises 2 parts: the type, which atria connect to each ventricle, and then the mode is the morphology of the valve guarding the junction. And then again, from the ventricle to the great arteries, there is the ventricular arterial connections, which is the third step. And there you have also type and mode, which ventricle connected to which great artery, and what are the morphology of the valves guarding the junction. And you end up by step 4, which is the associated anomalies, any number of associated anomalies you can get, like a VSD, ASD, PDA, and so on. And we'll see this as we go along in the lecture. So let's just have some basic rules about echocardiography. Let's explain the body and heart planes. The sagittal and coronal section, as you see in your picture here, is a vertical section, which is sagittal, and then the coronal section. But the heart is different because the plane of the heart differs from the plane of the body. So the sagittal and coronal sections would mean something else as regards from the body to the heart. So this is different. Once you know the orientation of the heart, because you can have a heart with an axis that's going correctly to the left, or it can be in a midline, or it can be going to the right, and then you fashion your views accordingly. So you do your cuts according to the direction of the heart. So the first thing you do is doing a subcostal long axis view, easier of course in smaller children. And as you can see in this view, we can see that the apex is oriented to the left. So because the apex is oriented to the left, we can then fashion our views according to the orientation of the heart. So this heart is oriented perfectly well in the correct direction of the heart, and then you can use your echo to cut. So I'll use short axis, I'll use long axis, and I'll use apical views and subcostal views. Of course, subcostal views are much easier in children, but you can do this with an apical 4-chamber view for adults. So, cardiac position. First thing you recognize when you put a subcostal view is the cardiac position. It is defined by both where it is, either it's in the left chest, in the midline, or the right chest. It's also defined by where the apex is. Is it pointing to the left? Is it pointing to the right? Is it pointing to the midline? This avoids confusion like terms like dextrocardia, which could mean the heart is just pulled to the right side, like in semi-Tartman syndrome. And then you have the short axis, subcostal short axis view, which is the sagittal views. This is a representation of this one. So from there, you can see the interatrial septum correctly to atria. You can see the outlet of the left ventricle in the upper panel. You can see the outlet of the right ventricle in the lower panel. And then you do your apical views. And from the apical views, you can see the apical 4-chamber. If you go anterior, you will see the aorta, which is the outlet. If you go posterior, then you'll see the coronary sinus. And then, of course, you're all familiar with the parasternal long axis views, the standard parasternal long axis. If you direct your probe superiorly, then you'll see the pulmonary artery. If you direct it towards the liver, then you'll see the right atrium. And then the usual parasternal short axis. And we have the suprasternal views from where you can see the aorta, whether there is like in this view where you have a very small PDA, and also the systemic veins and the pulmonary veins, which is called the crab view. So how do we start your analysis by echo? First thing is the first step, which is the atrial arrangement, the situs. So the first step in the sequential analysis is identify the atrial arrangement. How do we do that? I mean, the atria has 4 components: venous, septal, body, and vestibule, and appendage. The only thing that discriminates with the echo, the right atrium from the left atrium, is the shape of the appendage. So the left atrium would have a long crenellated appendage, and the right atrium would have a short, blunt appendage. So we have 4 variations. We have either the situs soletus, where the right atrium is to right, left atrium is to the left. We have the inversus, where the left atrium is to the right and the right atrium is to the left. And then we have an isomeric. What is isomeric? This is a unique clinical entity where there is duplication of the one half of the body along the vertical axis, and this only happens in the thorax and is quite rare. So you can get 2 right atria or 2 left atria. So let's see how this plays out. So you have the usual arrangement of the thorax, where you have the right atrium to the right, the right bronchus to the right, and the right pulmonary artery to the right, and the right lung, which is trilobe, to the left, and you have the right-sided liver and the left-sided stomach and spleen, and you have the mirror image where there is a mirror image of this arrangement, and then you have the right and left isomerism where there is duplication. And in both cases, there is duplication of a right atrium, duplication of a right bronchus, duplication of the right pulmonary artery, duplication of a trilobed lung for right isomerism, bilobed lung for left isomerism. You usually have a central liver, an absent spleen in right isomerism, and a polyspleen in a left isomerism. So how do we do identification by echo? In clinical practice, this is done by identifying the position of the inferior vena cava and the aorta relative to the spine. So in normal arrangement, you will have the aorta to the left if you do a short axis in the abdomen, and the IVC to the right. And in a mirror image arrangement, where the left atrium is to the right and the right atrium is to the left, you'll have the aorta to your right and the left atrium and the inferior vena cava to your left. How do you do that? By echo. So this is quite a representation, short axis of the abdominal view, where you can see the IVC is to the right of the spine and the aorta is to the left of the spine, and note that they are both, the aorta is pulsating while the IVC is pulsatile. And then you go along axis and check your views. So if you go to the right and see the IVC, so this is to the right, you go to the left and see the aorta, and then this is to the left. So this is how you say that this is situs soletus. What about atrial isomerism? Atrial isomerism can be right atrial isomerism or left atrial isomerism, as we said, 2 right atria or 2 left atria. How does this play out in the abdominal vessels? Both will be on the same side of the spine, either right or left. It has nothing to do with whether this is right isomerism or left isomerism. Both can be on the right side and both can be on the left side. In right isomerism, although the inferior vena cava will be anterior, and in left isomerism, the inferior vena cava 99% would be absent. So there is an absent suprahepatic portion of the IVC with azygous continuation, and the azygous vein will appear as a posterior structure. So this is an example. This is a patient with left isomerism, and you can see that you can have an azygous posteriorly. And what is very distinctive on the right side, you have your hepatic veins draining directly to the atrium. That means that the suprahepatic portion of IVC is missing, so then there is left isomerism. So what about, why is it so important to know it's right isomerism, left isomerism? Because isomeric hearts are usually associated with more complex anatomy. They are associated with conduction problems. They are associated with anomalous veins and arteries. And they are associated with maybe double inlet ventricles, AV septal defects. So it's very important to define. For example, with left isomerism, you cannot see where the SA node is. So it might be a one-rig pacemaker. Maybe these children are prone to arrhythmias, and they're usually very complex. So this is the correlation with the ultrasound. As you see, this is the usual soletus inversus with the vessels, and this is the right isomerism and left isomerism with the corresponding bronchi, corresponding lungs, and with left isomerism, the polysplenia, right isomerism, the asplenia. Now we finished the situs, so that means we know where the right atrium is, we know where the left atrium is, so let's say it's the usual arrangement. So we know that the right atrium is to the right of the heart of the patient, and the left atrium is to the left, and then we go to analyze the atrioventricular connection. So what do we analyze? We analyze the type of connection, so that means which atria connects to which ventricle, and then the mode of connection, which is the morphology of the valve guarding the junction. Very important to know how to define the right from the left ventricle, so this is ventricular morphology, and then ventricular relationship, which means which is right and which is left. Maybe there is superior inferior ventricles, maybe one of them is superior to the other. So this is one thing we have to look for. So how many components are in a ventricle? There are three components in a ventricle. There is the inlet component, the trabecular component, and the outlet component. Are they different? Yes, they are different. The right ventricle is more trabeculated. The left ventricle is more smooth. The tricuspid valve, which is in the right ventricle, has some septal attachment. It is different from the left ventricle. The mitral valve does not have any cordia attached to the septum, so the septal surface is smooth. You have a subpulmonary infundibulum in the right ventricle. You don't have an infundibulum in the left ventricle. So this is what you see actually. If you see a four-chamber view on your left side here, you can see that there is something called the natural offsetting of the tricuspid valve towards the apex. So the apex to the tricuspid valve appears more down to the apex than the mitral valve, and the reason for this is that the aorta is very central and it just pushes the mitral valve up. The reason we use the apex down orientation is to be able to identify right from left, because if you have the apex down, then you'll be confused about right and left. So with the apex down, the left side of the heart is the left side of the patient, and the right side of the heart is the right side of the patient. And then on your right, you can see the three components of the left ventricle. So there is the inlet and the outlet, left atrium to left ventricle and outlet to the aorta. In a subcostal view, you can see the inlet and outlet and the whole body in the left, at the bottom left corner, you can see the whole body of the right ventricle. So inlet, trabecular portion, outlet. And then on the short axis also, you can see the inlet, body, and outlet. So let's see what are the types of connection that we expect. You can have two biventricular connection, which means that each atrium is connected to a separate ventricle. And then you can have univentricular connection, which means the atrial chambers are connected to only one ventricle. So what are the possibilities? In biventricular, it can be concordant, discordant, or ambiguous in case of right or left atrial isomerism, because we will not be able to call them anything, because you have a right atrium to a right ventricle and a right atrium to a left ventricle. So you will not be able to call this anything. So we call it a mixed type or ambiguous type. And then univentricular, where the two atrias are only connected to one ventricle, you have three possibilities also. It's either a double inlet, it's either an absent right connection or absent left connection, namely tricuspid and mitral atresia. So this is an example of a biventricular concordant connection. You can see that the left atrium is connected to a left ventricle. Note that in the 3D view that the mitral valve has only, of course, there is natural offsetting of the tricuspid valve. You have no septal attachment on the septum on the left ventricle. You have some septal attachment on the right ventricle. So this is left atrium to left ventricle, right atrium to right ventricle. We identified the ventricles by their intrinsic morphology, by the valve getting into there, by the smoothness of the septum, not so much by the trabeculation, because trabeculation can vary. If you have severe aortic stenosis or pulmonary stenosis, you can have a heavily trabeculated left ventricle or a heavily trabeculated right ventricle, and then you won't be able to tell. So the best thing to use is the septal attachment, smoothness of the septum from the left side, and the chordal attachment on the right side. This is discordant, but you can see here that it is completely the opposite. You have on the right On the left side, you have the left atrium connected to a morphologic right ventricle. Note that there is some septal attachment. And on the left side, you have the left atrium connected to on the right side, you have the right atrium connected to a morphologic left ventricle, and this is a discordant connection. And then you have a biventricular or ambiguous connection, like in this patient we're seeing here, where you have a common atrium. You can see two appendages of left atrial morphology. So this is left atrial amesomerism connected to a left ventricle on the left and a right ventricle on the right, but then you can't call it anything, so you call it mixed connection. What about ventricular morphology in univentricular hearts? Ventricular morphology in univentricular hearts, we use completely different prospects than in biventricular hearts. So in univentricular hearts, you have a main chamber and a rudimentary chamber. How do you know the morphology of the main chamber? By position. So if you use the parasternal long axis and short axis, your rudimentary chamber is posterior, then the main chamber is right ventricle. If your rudimentary chamber is anterior, then your main chamber is left ventricle. So this is a univentricular double inlet ventricle. You can see on your left side of the screen, you can see this is a main chamber of RV morphology and then a rudimentary left ventricle. And we have to check this, of course, by parasternal short and long axis. On the right side, another example, opening via a common AV valve into a single ventricle. And this is what you see if you take the en-face view by 3D echo. You will see the two valves, the two AV valves opening into one single chamber. And then it can be an absent right or an absent left connection. So in this example, this is an example of tricuspid atresia, where you have an absent right connection, a left atrium connected to the left ventricle. You have to mention this because sometimes you have an absent right connection and the left atrium will connect to a right ventricle, so you have to mention that. And why do we say absent connection, not just atresia? This is to just differentiate between the what's called the membranous atresia and the muscular atresia. So we say absent connection, that means that there is no connection whatsoever between the floor of the atrium and the corresponding ventricle. So if you put a probe in the bottom of the right atrium, you will not go into the right ventricle, you will go external to the heart. So this is completely absent connection, so there is no inlet portion of the ventricle. But if you have an imperforate valve, say it's replaced by membrane, then you have a continuity between, theoretically, you can just remove the membrane and you'll have continuity between the atrium and the ventricle. So this is why we use absent connection to avoid the confusion. And this is another example of absent left connection. So this is a mitral atresia, and you can see on the right-hand side from the parasternal long axis view that the rudimentary chamber is posterior and the main chamber is anterior. So this is a right atrium to right ventricle. Absent left connection, right atrium to right ventricle. And then what about the mode of connection? So what do we mean by mode of connection? Mode of connection is the morphology of the valve guarding the junction. So what is this valve? Is it a normal valve? So this is AV connection, concordant, with two normal patent AV valves. This is common AV valve connecting, this is again AV concordance, but with a common AV valve like in AV septal defect. This is AV concordance with a stenotic mitral valve, so it can be stenotic. And this is AV concordance with a prolapsing mitral valve, so it can be stenotic, prolapsing. It can be a common valve, it can be two patent valves, two regurgitant valves, two stenotic valves, and so on. And then there is the confusion of straddling and overriding. So what is straddling and overriding? Straddling and overriding is a function of both the annulus of the valve and the chordia of the valve. So think of it like this: if you're riding a horse with both legs on both sides, so you'll be straddling the horse. And then if you're using the old saddle for the ladies that they used to use in the old Western films, then you'll be putting your legs on one side and still overriding the horse. So the straddling is a feature of the chordae tendineae, where they cross from one ventricle to the other, and then they are connected to the other ventricle. So it's a feature of the chordae. And overriding is a feature of the annulus itself. So the annulus is overriding the valve exactly like overriding a aortic valve. So let's think of it like this. So let's see about these examples. So this is a representation. So the first one on your upper left corner is a valve that is not straddling and is not overriding, meaning that the annulus stays in this place and the chordae tendineae is related to the same ventricle. And then it can be overriding, so the annulus is moving and overriding the septum, but all the chordae are in the same ventricle and they have not crossed. And it can be straddling only, so it is not overriding, but the chordae have moved from one ventricle to the other, so this is straddling. And it can be overriding and straddling, that means that the annulus is overriding the septum and the chordae has moved from one ventricle to the other. So this is an example of an apical. Well, how do you see them? You see them in apical and subcostal four-chamber views. And this is an example of a valve that is always straddling and both straddling and overriding. By the way, both valves can override or straddle. One of them can straddle and override, but this is too complex and I won't go through this now. But I mean, this is just a representation of straddling and overriding. So how do we deal with overriding valves? There is the 50% rule. So if the overriding is less than 50%, it will be a concordant AV connection. But if your overriding is more than 50%, it's going more to the left ventricle, as in this example, where there is 80% of the valve of the annulus in the left ventricle, and 20% of the annulus is in the right ventricle with a small rudimentary right ventricle, then we call it a double inlet left ventricle. So this is how we deal with them with the 50% rule. Having finished the AV connection, we could now go to step 3, which is the ventricular arterial connection. And then again, there is the type of connection, there is the mode of connection. There is the relationship of aorta to the pulmonary trunk, who is anterior, who is posterior, who is to the right, who is to the left. And then there is the infundibulum morphology. Do we have one infundibulum? We have bilateral infundibuli. Do we have a subaortic, subpulmonary infundibulum, or what? So starting by the type of connection, it can be concordant, where the left ventricle is connected to the aorta, right ventricle to the pulmonary artery, and this is how things should be. Can be discordant, where the left ventricle is connected to a pulmonary artery and the right ventricle is connected to an aorta. It can be double outlet, where both vessels are arising from the same ventricle, whether it is right or left, or indeterminate ventricle. When we can't see a rudimentary chamber, we can't really account for the morphology of the ventricle, so it can be right or left, or we call it indeterminate. Or is there a single outlet heart? A single outlet heart means that only one vessel is coming out of the heart. This can happen with aortic and pulmonary atresia, where there is only an aorta coming off the heart. With aortic atresia, where there is only a pulmonary tire coming out of the heart. Or a common arterial trunk, where both are, and we'll see, I'll explain this later, or something called a solitary arterial trunk. So what are these? An aorta is defined by a vessel that is in its origin. It comes immediately after origin. It gives off the coronary arteries and then continues as an arch. Gives the arch vessel and goes down as descending aorta. A pulmonary artery, what is the intrinsic morphology? It has a short course, quickly bifurcating into right and left. So what is a common arterial trunk? A common arterial trunk is a trunk that comes after the heart and then gives off the coronary artery at the start and then gives the pulmonary arteries again, whether they're by one origin, separate origin, whatever, continues as the arch, gives the arch vessels and then continues as descending aorta. And what is the solitary arterial trunk, which is previously called the truncus type 4, which is quite confusing, is the fact that you do not have intrapericardial pulmonary arteries. So you have a vessel that comes off, gives the coronary, gives the neck vessels, continues down as the descending aorta, and on its way down it will give pulmonary artery from collaterals. So actually there are no intrapericardial pulmonary arteries. So these are the variations of the single outlet heart. Pulmonary trunk only in case of aortic atresia, so only a pulmonary is coming off, and usually the aorta is connected by a duct, or an aorta coming off from the heart, like in pulmonary atresia, on the right-hand side, and this would be that there is a duct that is connecting to the pulmonary artery or giving blood supply to the pulmonary artery, or the pulmonary artery is supplied by collaterals or whatever. And then there is a common trunk, as we said, which is a trunk in its origin would give off the coronary pulmonaries, continues as the arch, give arch vessels and continues as descending aorta, or a solitary trunk where there are no intrapericardial pulmonary arteries, and then you have your pulmonary arteries coming off from the descending aorta or via collaterals or via duct or whatever, but they're not present, which is previously called truncus type 4. So these are an example for, this is concordant. You can see on the left-hand side the aorta giving off the aorta, and then the left ventricle giving off aorta, and on the right side the right ventricle giving off the pulmonary artery. So this is concordant. This is discordant, where you can see from the subcostal view the left-sided ventricle, which is the left ventricle, is giving off the pulmonary artery, and the right-sided ventricle, which is the RV, is giving off the aorta. And from the parasternal long axis views, it has a very distinct shape, where you can see the aorta curving down and the pulmonary behind it. And in this particular case on the right, there is some subpulmonic stenosis. It can be double outlet, also again, can be seen from the subcostal or the parasternal, and you have more than half of both great vents arising from one ventricle. We use the 50% rule, as we've said earlier on the AV valve, so it is the 50% rule. Or you have a single outlet, like in this patient with the common arterial trunk. You can see from the left-hand side, there is a large trunk giving off the pulmonary arteries. And from the parasternal long short axis, it's a very large origin of the trunk. And usually the leaflets are quadrileaflet. They are not usually trileaflet. It's a large trunk dilated root, and usually it is quadrileaflet. Or a single outlet heart, like in this patient where he has pulmonary atresia. You can see that only on the left-hand side, only the aorta is coming up from the arch. You can see the aorta because it's arching all the way. And then you can see from the parasternal high parasternal view that the pulmonary arteries are there, but they are only supplied by continuous flow, which is a patent ductus arteriosus. Having done with the type of connection, we now move to the mode of VA connection. So again, the valves can be normal, they can be imperforate, can be stenotic, can be prolapsing, can be overriding. One thing is different from the AV valves. There are no straddling and overriding here, only overriding, no straddling, because there are no chordae tendineae attached to the semilunar valves. So you have normal, imperforate, stenotic, prolapsing, and overriding. So this is an example of an aortic override. It can be an aortic override, it can be a pulmonary override, and again, the 50% rule applies. So let's see what we've done there. So I've told you before that this allows limited variability in segments. Does it? Yes. In the atrial, there is limited variability. You have two morphologic type of atria. It's either right or left. And in ventricular, you have three types of morphologic ventricles. It's either a right ventricle, a left ventricle, or an indeterminate ventricle. And then for the arterial tree, there are four types, which is either it's an aorta, pulmonary artery, common arterial trunk, or circulatory arterial trunk. So there is limited variability in the segments. Once we've finished all that, we then catalog all the associated anomalies. Associated anomalies can be like an ASD, like anomalies of the pulmonary and systemic vein, and you can see in the bottom pictures here, there is total anomalous pulmonary venous drainage, there is a persistent left SVC, there is an SAD and the ASD, there is a VSD, or any number of associated anomalies that you can catalog, and you have to write them and see their impact on your echocardiograph. So in conclusion, what does a sequential segmental analysis offer? It offers a logical approach to analysis. It offers a common language that we all understand. It accounts for all cases, so instead of saying just a TGA, maybe some people would say, this patient has a double outlet right ventricle with a TGA. What do you mean? You can say a double outlet right ventricle with an anterior aorta posterior pulmonary artery. This would be more understandable to the surgeon, because at the end of the day, most of our treatments in complex congenital heart disease is surgery. So you have to envision the picture and give the surgeon a very clear picture of what he's going to see inside. There is no room for mistakes here. So you have to tell him the morphology and the anatomy properly. So you just describe what you see, and makes you figure out at the end of the day how the circulation is going. Is the deoxygenated blood going to the pulmonary artery as it should, or it is not reaching the pulmonary artery? Is the oxygenated blood reaching the aorta to be distributed to the body, or it's not reaching the aorta? Is the flow in the pulmonary arteries overflowed? Is there an obstruction to the flow to the pulmonary artery? Are the lungs protected? These are important questions very important clinical questions, and very important clinical questions for the surgeon to answer to for your decision making, because here echo is a decision making tool where you would decide what are you going to do with your patient. Are you going to keep him on follow-up? Are you going to send him to the surgeon? And if you're sending to the surgeon, what do you envision the surgeon is going to do? So you can discuss the case with the surgeons. And or you just give him medical treatment, or you use intervention, or you use maybe the patient just has an ASD and you're going to close it by a device. And thank you very much.